get things started. I gave this lecture to our residents at Madigan this past April at their senior transition seminar, their little conference that they have before graduating residency. And I thought that it would be really helpful to give this to anyone else who's graduating and who may have questions about the next year that's to come. So I hope you find this helpful. I have the chat pulled up, so if you want to put any questions in of anything I said, I can actually see it. I figured out how to do that. But to get started, so we stay on time, I'll talk a little bit about who I am first. So here's just a couple pictures of me. So currently right now I am a staff physician at Madigan. I am with a unit, but they basically lend me out to Madigan to be primarily staff there, which is great. So I work directly with the residents. I'm in my second year of doing this, and I will currently be PCSing in the next 2 weeks to go to a new unit in Tennessee where I will serve as a flight surgeon for a medevac unit for the next few years. So just starting from left to right, I graduated USIS from 2022. I attended the flight surgeon course. The picture on the left is me and my USIS classmates who went to the course together. My husband's currently a resident. This gentleman in the middle, he is graduating from his residency program on Friday and will be joining me out in Tennessee. I grew up in a military family. Both of my parents were military active duty physicians growing up, so I have a lot of influence in my life, and actually I have pretty good mentorship of what to expect throughout this career, which has been very helpful. And the bottom is my residency class. They help support me through the whole craziness that residency is, and we're all still really good friends. It helps that 6 of us were USIS classmates, so half the class. And then this is just a silly picture of when I really wanted a TDY paid for by GME. So I was like, well, I'll just submit every single case report I've done, and they accepted all 4. So if you want to get a funded TDY from your GME program, then submit a poster to GSACEP. Even as a staff, I'm sure that they would take you. All right, so to start off with our lecture, this is something that you guys will be receiving in the mail soon, or at least have your programs hand out to you. So it's nice, can go on your fridge, easy to hold and use. So I'm going to be using this checklist for the next couple of slides to talk about things to expect once you graduate residency. So I know that the left side is obviously finished. We've been through April. We're now in June, so we'll focus more on the second half. What else you should be receiving from your programs are these packets, which are personalized and talk about, welcoming you to the team as being attendings and letting you know that GSACEP is here for you if you want to continue to be a part of our team. All right, let's move on. So just to start off, so what should you be doing right now? You're getting ready to graduate, or you've already graduated if you're at BAMC. But from a board exam standpoint, what opened in May was applying for your ABEM certification. And the reason why I ended up putting this checklist together is I didn't realize how much money things were. And on top of PCSing and moving, which also costs a lot of money, this is costs that aren't reimbursed to you until you actually pass your boards, if your unit or your GME program will actually refund you. So I put these here to ensure that you have that money saved up to register for your exam and to certify. So the first thing you do is apply for ABEM certification. So you go to abem.org, you have to create a profile. A lot of your programs at Madigan specifically, they use the incorrect email. So if you have not yet received an ABEM certification email, then you need to reach out to them because it possibly is going to the wrong email. I would put your civilian address because if you're PCSing, it's not really easy to access your military email. But anyway, so the first thing you do is apply for your ABEM certification. That out front, out of pocket's $420. You have to let them know, or basically what this is saying is your program is given the thumbs up to ABEM that you're graduating and ready to take this exam. And then starting really just this past month, the written exam registration opens, and that is $960. You have from the end of May until October 10th to register for this exam. If you try to register on October 11th, the fee goes up, so just something to keep in mind. And then next is to think about doing credentials, get your peer evals, which every single DHA facility requires, and then work on out processing. And then August to September, this is where you'll start getting settled in your new installation. And what you'll want to do is when you start working is you no longer really have, I mean, technically you still have my evals or any other method that you've been using to track procedures, but create an Excel sheet to help track your procedures to ensure that you're staying up on your ICTLs or KSAs, and also find a way to track your CME. So CME is required for all medical licenses, so state licenses, as well as through the DHA, they require you to submit CME as well. The easiest way to do it is ensure that you're logged in up to date. You can quickly get hours that way or logged in through Open Evidence. So anything you search will give you a half hour. If you're interested and want to attend, ACEP will be in Salt Lake City in the beginning of September. Unfortunately, will not be there, but it's always a good time. If you have dependents, then ensure that you are establishing care for them at the new MTF. And anytime you move, this is a good time to review your SGLI, ensure that your spouse or your parents or the people who are going to receive that if something happens to you, ensure you have an up-to-date will and testament, and adjust your TSP. Because when you move, your BH may not exactly, or your BH will change, but your base pay may not. But if you are coming from a civilian program, that this may all be new to you. So there's lots of calculators out there that can help you figure out how much it is, but then you have to convert that to percentage of your base pay, so it gets a little confusing. One other thing I would add is SGLI is great, but it's only 500,000. So if you are buying a house that's over 500,000, then and you want to make sure that your spouse is taken care of, you should look at other avenues for life insurance as well. Or just in general, your net worth is going to be more than 500,000 over the next couple years because you are a physician, which is great. And then in October to November, you want to start applying for your specialty pay. So October 1st is the first day, at least for the Army, that you're able to apply for your specialty pay, your specialty bonus that is given for emergency physicians. The stipulations written out in the doctrine say that it's 90 days post-graduation. So they're saying that you're done on July 1st or date of credentialing. So when I say make sure that you're starting to get your credentialing stuff together, start really soon, because whichever is the later date, October 1st, or when you're credentialed, is the one that they will document to allow you to start getting paid your specialty pay. I would say that that is probably the most, the biggest learning curve I had as well, is that you are working as an attending for probably a couple months and you still are not getting paid that way. Anyways, and then your written boards are going to be from November 3rd to 12th, so find a way to and method to study. So this will be given to you all, hopefully from your programs pretty soon, and we'll talk a little bit more about boards. So like I had mentioned before, so applying for certification, this is what it looks like on the website. Log into the portal up here in the upper left corner. Here are the specific dates. So you need to certify and then register for your exam, and then understand when the fee goes up. So like I said, if you do it too late, then it's going to double in cost. And same for actually registering for your test as well. If you register too late, then after October 10th, it goes up to $1,200. So save your money any way you can. Put those dates in your calendar or just do it in the next week on your to-do list. And it goes through the same thing. So I know that this was a learning curve for me. Does anyone have questions about certifying and registering for your exam? I don't see anything in the chat. All right, so for military pay bonuses, as an emergency physician, so fully qualified, you have a bonus of $49,000. This is what you will start getting paid on October 1st once you apply. If you don't, you really won't see that until January. So just ensure that you are not completely paying or expecting that income. You will get back paid to October, but don't completely rely on it because I did not see mine until I think February, and the majority of my classmates as well did not. And then there's also the board certification pay, which is $8,000, and you'll get that the next year after you finish your oral boards, and that is taxable as well. All right. Let's talk a little bit about what to expect as you're starting your first shifts. So there's some things that you should think about before you do your first shift that at least I did that helped me feel a little bit more comfortable. So write down topics that scare you and try and review those. It will give you confidence that you actually know what you're doing. So one of those things, for some reason, I was like, no matter what, an emergency hysterotomy is going to come in on my first shift, and I'm just going to need to know how to do that, or at least guide the residents through that. Or even having to place a Blakemore tube, things like that that I hadn't really thought about in the past 6 months, all of a sudden were starting to worry me. So the way that I did that is I just sat down, made a list of things, and just review them, put a little check mark by it. Like, I got it. We went through this all residency, and I know how to do it. Specifically procedures, but we've gotten enough touches that you know places to look it up quickly, like WikiEM or Corpendium, that you can quickly review the steps of how to do it. There is nothing wrong with looking up how to do the procedure if it happens. And then also review topics you don't have much experience with. So for example, something that specifically occurs at Madigan is because we have so many other training programs with us, reductions is something that we didn't exactly have too much experience doing, but in the community, this is our bread and butter. We have to know how to do this. So this was something that my colleagues also said that they felt a little bit behind the curve with graduating. And the nice thing is that there are a ton of videos looking that can show you how to do these reductions. The next thing is you may notice is that your practice may change. When you have the comfort of multiple lines of people telling you that your plan is good or things sound great or you're doing the right things or how about we try to do this, you recognize you don't exactly have that support when you're working as an attending. So you may notice that you may be a little bit more conservative, which is super, super normal. Your risk tolerance may change. You may feel like you are going to send patients home with medications that maybe you wouldn't have, like, for example, like an antibiotic, just because you are feeling a little bit insecure, but that's okay. It's all a learning curve. And like I said, antibiotic stewardship, you may find yourself covering things a little bit more or having people come back for reevaluation. The next thing I want to talk a little bit about as well is imposter syndrome. So it's incredibly normal to all of a sudden be questioning the decisions that you're making now that you're on your own. You may be questioning sometimes if this was the right decision. Should I have done emergency medicine? There's no way I had enough training. What am I doing? it can be a little bit disheartening and a little bit scary because I feel like when you are in your last year of residency, it's kind of a high, you feel super confident and comfortable, but it happens. It's totally normal to go through this. And some things that I have found that have helped me go through this is to find a hype person. So someone who will always put you up and let you know that you're doing the right thing or you know what you're doing. I found that specifically to be my husband or my parents. So I'll reach out to them and say, hey, does this sound like a good plan? Or I'm feeling a little nervous about my shift. And they're like, you know what you're doing, you have the right training, you've got this. And it's also nice to find someone that you can bounce ideas off of as well. So if you have a trusted confidant or a residency colleague, or even just an advisor or mentor, just let them know, hey, this is my first shift. I would love to have you here in my pocket if I have any questions. And most people will say yes because they totally understand what you're going through. Other things that can help with this is just to look things up. There's no shame in reminding yourself what to discharge someone home who has a kidney stone, right? Look things up, reassure yourself that you're doing the right thing, and you'll feel better. And then also something I have found helpful is just asking for help. Most people are not going to do a single or a solo coverage overnight shift in a new place as a first time attending or for their first shift in general, except for one of my classmates actually did that, and I applaud him. That sounds very scary to me, but there's nothing wrong with asking anyone else who's on shift with you for some help or, hey, to look at this EKG. Am I seeing anything abnormal? So just keep that in mind. It's completely normal. And those are some things that I've found to be helpful. And I kind of like this picture. So all of a sudden you feel like you're in your school of fish, hanging out at the reef, and then you're alone. You're like Dory out in the middle of nowhere. And it's kind of how it feels. But as one of my colleagues who gave this talk to our residents the past couple years, is imposter syndrome. It happens to everyone, and if it doesn't happen to you, you're probably overconfident and lack self-awareness. So keep that in mind. It's normal to feel, and if you're not feeling it, then maybe you should take a second and self-reflect. All right. So next steps is we are in a specialty and just in general, our profession is where we never stop learning. Things are constantly changing. I could tell you even since me being a medical student and, fairly junior attending, things have completely changed. So like we had previously said, make sure you have a method to track your CME. So like state for ABEM, like I said, sign into UpToDate, procedure tracker. I have one that if anyone's interested, I can send you as an example as well. But anything that works specifically for you that you have found. And then create a routine. So there's lots of different things that you could use to help continue to learn. And I'll kind of go through them. Let's see. Oh, the pictures are gone. But anyway, so MRAP, if you don't already know, it's 50% off for active duty personnel. It's not a coupon code. You specifically have to reach out to them and say that you're active duty. They'll want a copy of your orders or something that shows them that you're active duty. And then you can use that discount. So you're not paying, I think, $500 to have it. If you create a weekly routine, hey, I'm going to listen to MRAP every Monday or during my commute, that could be really helpful to stay on top of things. ECG Weekly, if anyone hasn't heard of this, it was created by a former Army emergency physician as well as Amal Mattu. It's very cheap. I think it's $20 for a year. And Dr. Mattu puts out weekly videos with ECGs that talk about management and cases, and it's really super helpful to stay up on that cardiology literature and to know everything that I feel like these intricacies we don't specifically focus on in residency. EM Sono is created by the same gentleman, Army physician who created ECG Weekly. Could be helpful if you want to catch up on your ultrasounds or feeling a little rusty, or 5-minute sono as well. And then something else that I recently saw on the EM Docs Facebook page is two EM physicians created this Rapid Rads online program, which I think was only $100 to sign up completely for the program. And it goes through how to read your own radiographs because a lot of places you may not have any radiology support overnight to read your x-ray. So you are the person who's looking at this and being able to know if they need to be discharged or sent up for higher care. All right. So any questions about any of these programs? I don't see anything in the chat. Next thing let's focus on is off-duty employment. So I have been working in the community for the past year at two of the higher level of hospitals, community hospitals. So one of them is a level 2 that has basically every consulting service there, which is great and helpful. There's no residents, so I'm working on my own. And then the other one is a level 4, not a trauma center, but more of like a critical access, and we see more your bread and butter community medicine. Oh, just got a question. Do you have any go-to apps? I do have some go-to apps. Corpendium is super helpful if you have the MRAP subscription. And then let's see what else. That's kind of it. I liked the WikiYem app, but they changed it and now it's just too challenging to navigate. I just use the website. But there's also a couple of radiology apps that one of them is I think called Cortex, which could be helpful and talk about displacement. Let's see. I have these apps on my medicine, but I obviously haven't used them too much. Oh, the EMRA antibiotic guide, amazing. If you don't have that, it's worth the $10. And oh, MD Calc for sure. I use that all the time. Let's see, there's one more. There's the suture app that can help talk about follow-up, and it actually gives discharge instructions. If anyone hasn't used it before, I really do love Open Evidence. It is super helpful if you just have a weird question about management, or it can even give you a differential, which is really great. I used one recently. I was like, what should I be thinking about in a person who's on this weird monoclonal antibody medication and they have a rash? It's just really helpful. I can't find my other apps, but there's a couple others for specifically for fractures and management of them. If I think of them or find them, I'll send them out. All right, so back to off-duty employment. My big advice is take your boards first. If you fail your boards and you have to wait an entire year to be able to take them again, you're also out of pocket another $1,000 and you're behind an entire year of getting your specialty bonus, or at least your board certification bonus of the $8,000. So focus on that. Don't start moonlighting until you're able to get that taken care of. The next thing is just to be careful. Make sure you're doing it the proper way. There are people who have gotten in trouble who have done it without command support. There's people who have gotten in trouble because the hospitals or the systems are charging for TRICARE patients, which if you are a active duty physician and working in the community, you cannot get paid for taking care of TRICARE patients. So that has to be a stipulation in your contract, or at least have them be aware of this. So make sure that you're reading your contracts, make sure that you're slowing down and focusing on what's important, which is becoming board certified. The next thing I would say is also to get to know the location. So before I started, I did orientation shifts at both of the hospital facilities that I worked at. I wanted to know where the crash cart was, what the order sets looked like, what are some helpful dot phrases that they use within their little network of physicians there, as well as who calls consults, how do we do follow-up, things like that. Or also, where's the bathroom? Just in general, things like that could be helpful. Some places have a doctor's lounge and they have lots of snacks in there. But I wasn't offered any of these. I had to reach out and say, hey, do you mind if I come onto your next shift and just hang out with you for an hour or so just to answer questions? A lot of these very efficient community hospitals have amazing dot phrases. For example, like the place I go to has dot phrases for every single chief complaint, differential diagnoses. So it saves me a ton of time so I can mentally offload and not have to think about every single chief complaint. They also have a lot of templates that I stole from the medical director. So get to know people, see what they do. You don't make money for charting after your shift, so do it efficiently. Well, most places you don't get paid after for charting. And then before you sign a contract, just make sure you ask about the resources available to you. What consultants do you have? I mean, do you have a cardiologist? Do you have peds? Who's admitting? As well as patients per hour. Some places will look amazing. They will want to pay you $500 an hour, and then you realize that you have to see 3 to 4 patients per hour, and it's just awful. So sometimes the money is not always worth it, and it's unsafe. Ensure you know when you're going to be solo coverage, and then make sure that you also have malpractice and tail coverage in your contract. And then the last thing I always ask about is, am I going to have to read my own studies? Because I'm okay at it, but not perfect with radiographs. And do you guys have a place that's easy to transfer? Because most of these community hospitals are not going to have neurosurgical services, or sometimes they'll have ortho, but definitely not peds. So ensuring that they have a good system set up with the surrounding tertiary centers. All right. And then I always say start with 2 shifts per month. I had a friend who signed up for 8 shifts in her first month, which for one is technically, actually, I think that's within regs, but regulations say that you can't do more than 16 hours weekly. So make sure you're actually following regs for one, but I would say start with 2 shifts per month and you can always do more. I would also say start at one single place. Learning 2 different hospitals is very, uh, just puts a lot of task saturation on your brain and figuring out how everything works, as well as the new military hospital you'll be working at. My next piece of advice is, now that you're graduating, take back your life and your free time. It is crazy how much free time you're going to have. And it's honestly just so nice. Take all of your leave, use it all up, spend time with your family, make yourself a priority. I went to multiple weddings. I went on so many trips and vacations. I made it a little bit of my say yes year. So just going out and having fun with people who I haven't seen in a long time, I felt was really important. And then the next thing is, you can get involved as much as you want. There's a lot of different ways and avenues to do so. So one thing specifically that I did was get involved with GSACEP. So I started basically right at the end of my senior or my last year of residency with doing the leadership fellowship, which was really super helpful in getting involved. But it was nice to have this new community to learn different ways of helping out or being a part in impacting military emergency medicine through GSACEP. The next thing I did pretty much right away was get my USU professorship. So if you work in any hospital that interacts with USIS medical students, you can get a USU professorship in military and emergency medicine. So by working at Madigan, we get a ton of rotators from USIS, which is great. But one thing that I really was excited to get involved with was the different operational activities that they have throughout the year. So they have 4 different throughout the year because each class has their own. But specifically, the ones that I spent time with were gunpowder and Bushmaster. Gunpowder is with the 3rd-year medical students, and it will be in March of this upcoming year. And it is focused primarily on prolonged field care. So what happens is you are with a group of 10 to 12 students and you follow them throughout the entire night. Last year, was a little bit better because they made schedules, so I wasn't with them the entire night, but the first the first year they did it this way, I was basically with them awake for 36 hours, which was a little draining, but it was very fun. Medical students are super eager and excited to learn. It can help a lot with burnout and just, I don't know, just they're excited, and it's nice to be around people who are happy and excited. And Bushmaster, I did this past October of last year. There's two iterations in October, I think mid and then late. But depending on what you are interested in, I specifically worked with the fourth year students who were in the role of the battalion surgeon. So I basically just assessed them on their skills and how they were taking care of patients. So this first picture up here is my platoon from one of my iterations of gunpowder, which is really fun. I mean, these guys are all smiling after being awake for 36 hours and taking care of their patients. So it wasn't a terrible time, but they're pretty bright nowadays. And this bottom picture is me kind of staring off into space, I guess. But we have our first year medical students who are acting as the patients and the fourth year students who are taking care of them. So seeing how they go through their March algorithm is super helpful, and it's fun. You know more than you think when you have graduated residency. And then the next thing is go to conferences if you're able. So there's lots of different conferences. This is not an all-inclusive list that can help you get CME to learn more and to try and excel your career. So upcoming, there's ACEP, there's a Government Services Symposium through GSACEP, SOMA, which is the Special Operations Medic Conference, or Scientific Assembly, SOMSA, which occurs every May. And annually, ACEP puts on a couple of different teaching fellowships, which is something I have on my list to eventually attend, and then EMBERS, which is the research symposium to learn more about medical research. But there's also the AAEM conference, and there's MHSRS. There's honestly an endless list. It's really how much money you're willing to spend to go to these things. But specifically for GSACEP, we put together a grant, which is specifically geared for attending physicians because we don't get CME money versus our civilian colleagues will get CME money to attend these type of conferences and to learn more. So if you're interested in applying and have found or interested in going to these conferences and found money to be prohibitive because these are very expensive conferences, other than GSS, it's definitely way more affordable. You can apply for this grant, and we would love to help support you. And I specifically made this for our Army residents, but this is fairly applicable to all services. So some tips I had, because I initially was in a general Army unit, and then we ended up coming up with a contract so I could specifically work at Madigan because they didn't need me on the day-to-day for the unit. But if you are in a regular force comm unit, your commander may not know anything about what you do. So specifically my commander, she is a logistics officer. And when I had talked to her about doing off-duty employment, because you have to have command approval, she asked me if it would be okay for me to just volunteer at the hospital. So she has no idea what ER physicians really do. It was quite eye-opening when I had learned about it. I had a couple of my company commanders, so they asked me when I was graduating residency, and I told them I had graduated last year. So just ensure that they probably will know nothing of what you do unless they have any family members or friends who are physicians as well, or if they're a physician themselves, which would be super helpful. The next thing I would say is if you are in a regular unit, ensure that you're showing face. Show up to teach your medics or your corpsmen. They really want to learn from you. You are the subject matter expert. And if you are around at least a little bit, they'll remember that and they will be very thankful. The next thing I have on here is embrace the suck, expect the unexpected, and roll with the punches. And I'm sure anyone who is more senior than I on here can understand what this means, but specifically, things are going to change. Unexpected TDYs or taskers are going to come up, and you're going to have to change your plans, or you're going to find yourself for a week in the field with no heaters in the winter. Or you may have an upcoming deployment that you're required to go to, but these things happen. You're trained for this, and just roll with the punches and try not to complain. I know it can be hard, but it's going to be okay. And like I had previously talked about was showing face is just training your medics, get to know your PAs. I would say specifically for the Army, a good PA is worth its weight in gold. They know how the Army works or the military in general, and they can really help you with navigating how to do things. So get to know your PAs and keep them in your back pocket to reach out to. One other thing I have on here is an I Love Me binder. I'm gonna grab mine just to share. Sorry, I'm in shorts. I didn't have the opportunity to show my residents when I gave this talk initially, but this is my I Love Me binder. This is everything in paper form that I have been given from the Army. So I have it all divided out just in organized. We have a lot of stuff online, but don't expect that as your primary. I mean, I feel like there's so many times when I've looked on there and things have gotten lost. Your awards for some reason aren't uploaded, so that it's not reflecting for you to be able to wear them. You're frequently going to get asked for your oath of offices or your OERs. And I don't know how it is for the other branches, but the Army keeps on changing systems. I've gone through 4 different emails since I've been in the Army since 2016, which is crazy. But basically, I have this all organized. I did it before, right when I graduated, and my husband just put his together before we're moving. And I have all things printed off from online. I have my flight surgeon stuff, my oath of offices, my officer evaluation reports, and all my AERs from medical school, all my military memos, such as me changing my name. I put all of my awards in here, which can be helpful. Like I said, I had 3 awards that weren't uploading onto my actual profile. So technically you can't wear them if they're not uploaded. And then I also put some important civilian documents like my taxes and stuff in here. So that's why it's a large binder. But find something like that. We in the Army have called it an I Love Me binder. I don't know if it's called that way um, for anyone else or any other branch. All right. Let's see, Dr. Ajar, how did you identify medic training needs upon entering your unit? Awesome. So that's a great question. So specifically, every single medic, depending on what their capabilities are. So if they're a flight paramedic, they're going to have different ICTLs than a plain old 6-8 whiskey, which is a plain old Army medic, Army combat medic. They all have lists of what is required of them, just like we do. So taking a look, you can literally Google that and take a look and see what those training requirements are. And my platoon leader, because we are a medical platoon, put together a schedule. So we did weekly training on Thursdays, and I think I went and I helped with like 4 or 5 times. So they had different topics that they went through just to cover and ensure that they had gotten through those ICTLs. And some of those also included like maintenance for our supplies and stuff. So that's really helpful to ensure that your stuff is up to date. Let's see. But basically, it was putting together LTT is what we call it. I think it's leader time training. And if you are a battalion surgeon or flight surgeon yourself, that onus may be on you to put together the LTT. So don't reinvent the wheel. Just take a look at the ICTLs, put together a specific week or day of the week or 2 days a month that you are going to have dedicated known time to spend with your medics. So ensuring that they're not on motor pool duty and can actually attend. All right. Any other questions with that? And the next thing I have on here is who is your rater? So specifically for the Army, we have our officer evaluation reports, which is annual. When I initially started in my unit, my rater was going to be my battalion's, my brigade. Who was it going to be? My battalion commander, who had previously not even really known what an ER physician does. So make sure that you're meeting with them, they're getting to know you, and that you're able to help show how awesome you are and everything that you've done for the years. So keep a running list of everything that you've done, even if it's like a quick lecture, a quick chalk talk, anything like that. If you had anything published, they love numbers. So I gave 7 lectures to a total of 30 medics. So I affected all of these people. They love that type of stuff. So get to know them and make sure they get to know you too. The next thing I'd say is take the TDY opportunities. They will be plentiful. If you have the ability to go to the Philippines or go teach medics in Australia or go to Thailand, anything like that, I would just volunteer. Why not? Nothing, it's all temporary. There's endless supply of TDY opportunities and trainings and fun things that you can do. That's what makes being in the military so different than being a plain old civilian physician because we have the ability to go do all these fun things and get paid for it. And the last thing I would say on here is to make sure you know the JTS CPG. So for those of you who aren't sure what this is, so this is the Joint Trauma System Clinical Practice Guidelines. You can find all these on the Deployed Medicine app or on deployedmedicine.com, I think, or .org. But basically, these are the guidelines that we will be judged upon when we are deployed. They are the standard of care for every patient that we could be taking care of. They have been reviewed and updated constantly by subject matter experts in the military. And it's just important to know what your clinical practice guidelines that you will be judged upon. So take the time. I know that some of the medic training that my colleagues have done is to go through each of the CPGs with them and to understand for sure what T-TRIC is, ensure that we're all on the same page. So if you're looking for another way to put together a curriculum, you could go through those so everyone knows. And so you're teaching it and you're learning it yourself. But the Deployed Medicine app is awesome and it is easy to access on your phone. All right, so this is what I said about TDY opportunities, and I kind of laugh because I have a very stern face in basically every picture, candid picture that I have taken of me. But when I say embrace the suck and take the opportunity, just do it. This was me in Alaska. The left was in the fall, or excuse me, in the summer in August. It felt like fall. And the right was in January, where I went to the mountain medicine course that was paid for by my unit. And I got to get my diploma in mountain medicine. And I spent about a month climbing and hiking and learning some austere medicine. It was really fun. These are some of my medics, and this is my colleague, Major Galler. He is also an ER physician in my unit, and we are teaching our medics how to do chest tubes, and we're able to rent out a few of the simulators from the sim center. Most places should have sim centers, and they'll easily hand receipt anything to you to borrow. On the right here was in July when they told us we were going to be in the field for the next few days. So I put together a journal club. This gal here, she was one of our critical care nurses, and then Major Luzo, he is our awesome PA, and we put together a journal club on why TXA is helpful, and so we could just, be smart and hang out, but honestly, we just wanted a reason to sit down in the shade and chit chat, but we, spun it as it's a journal club. On the left here is my medics and I were running patient scenarios. Our company commander, he came up, and our platoon leader, they came up with a ton of scenarios and they chose patients from our soldiers who weren't directly involved with patient care. And they allowed us to do IVs and in practice, and it was really good to run these trauma lanes. As you can tell, it is very cold. We had no heat. And I think it was in the end of October, but for some reason it was in the 40s and 30s. These pictures here, I was able to attend a CBRN course and take care of patients who have been exposed and learn what that's like. It was very warm being in our MOP 4 gear, but it's always a fun uh, learning curve to be more involved with those patients that we don't really think about, but we talk about. And typically they're decontaminated once they get to the emergency department, but here we were actually taking care of them from point of injury, which is pretty fun. And this last picture here on the bottom was me helping out my medics learn some physical exam maneuvers because when my unit specifically is PACOM, so they have been out in the Philippines for the majority of the year, really, and we don't have any providers out there. So they're having to do these exam maneuvers. They should learn their Ottawa knee rules. We don't have x-ray, so if they have any concerns and they have to send them forward to another hospital that actually has these capabilities. So teacher medics, they're sponges. They want to learn. All right. And then some lessons learned that I have is it's okay to ask for help. We're all learning, forever learners. It honestly, I was in one of my first shifts and one of the more senior physicians on my off-duty employment shifts came over to me and was like, this headache seems weird. I don't really understand what's going on. I CT'd her. I actually did a CT venogram as well because she's having eye pain, but everything's negative and something doesn't seem right. And he was bouncing ideas off of me. And I said, well, did you maybe check intraocular pressures? And sure enough, it was actually headache mimic of acute angle closure glaucoma. So it's okay to ask for help. You are not too senior to ask and bounce things off of people, and you're not too junior to try and ask anyone around you if you're doing the right thing. The next thing I will say is that mistakes are going to happen. You're going to accidentally discharge someone without a lab coming back or a feeling like you looked at the radiograph or CT read and you actually didn't. So give yourself grace. Mistakes happen. EMRs are challenging to ensure that you're seeing everything, especially if it's something that you haven't used before. But slow down, come up with a system. I tell my residents, I look at 5 things before I know a patient's good to discharge home. I review the vitals. I review all of the labs and the pictures. I look at the triage note because sometimes those are hidden, and then for some reason the triage nurse will throw something in like they're here for their eye tearing and also they have chest pain, but then they never mention the chest pain to you. You're like, what the heck? And then there's one more, but I'm blanking on it for a second. Or following up, reevaluating the patient. But I have those 5 things I do before I completely click and discharge the patient. But so come up with a system that's helpful for you, but give yourself grace if you miss something. We are human beings. And then the last thing I would say is have someone you can call or text to support you. Like I had told to my residents who are graduating when I gave this talk, is anyone could call me. I'm here. I, for some reason, have insomnia and never sleep, but find someone there that you can mentally offload after a shift, or you can call if you need just a little bit of help because you'll see weird things that you never imagined seeing or never thought you would, or you don't know what to do. All right, so before we end, I'm going to go into a couple of lessons learned and I'll read these out loud for y'all. All right, so the first thing, you don't have to know everything, but you do need to know what's dangerous. It's okay to ask an attending or attending. There will be days when you feel like a fraud. That's normal. It fades, but always stay humble. There's no mastering medicine, just getting better. Your duty station might not have the resources you trained with, and your deployed setting almost certainly won't. So be ready to adapt. And I actually got these quotes from other physicians on EM Docs and at Madigan. And through GSACEP too. So another one said, I wish I knew that I could reschedule my boards. I was told I was deploying 2 weeks before my written boards, failed them, and had to retake them. It was extremely stressful. I wish I knew more about retirement accounts, LLCs, and how to maximize retirement contributions. So I haven't found a good resource for that specifically either, but find someone at your duty station who's currently moonlighting or doing off-duty employment and try and learn more from them. I think that maybe that's something we can put together as a upcoming seminar is how, or financials in general and moonlighting. So more to come. So 10 lessons learned from this person. So you're going to feel like you're not ready on shift 1, but you are. You probably will get sued. I did. It was frivolous. Most are let the lawyer's lawyer, but come to work every day ready to advocate for your patients and do the best you can. Recognize you have the best training in EM on the planet. If you get sued, it happens. 3, be conservative at first and back off as needed. Don't let the rad techs tell you order too much. And don't feel bad for ordering things that you feel are indicated. 3, 4, don't let your nerves come across as pretension. Be happy and calm on the outside, even if you're not on the inside. The team will appreciate that and rally for you. 5, bring snacks. 6, if you moonlight at a few places, write the names of your shift staff members down on your patient tracker for the shift. You'll get more team points if you can say, hey, Laura, would you mind helping me with this? Rather than, hey, nurse. 7, eat. 8P. 9, try to leave work at work. Find an activity to conveniently decompress and set that as a routine and one that's achievable. And 10, call or text your old attendings. We don't mind. They don't. The sick patients aren't really the hard ones. Your training will kick in for that. The hardest ones are the patient complaints you've never really saw much of in residency, and then boom, now you have to figure out. For some reason, it's always a rash. Doing a favor for a consultant or a hospitalist will make that consultant your new best friend. One time I tapped a knee for a notoriously difficult hospitalist and he never gave me grief again. EM is a slow burn. While you may have bills and loans to pay, working yourself like a dog for the first few years will completely burn you out. Take great care of patients. Metrics are always number 2 to patient care, and don't let anyone tell you otherwise. Critical care billing. Reach out to your billers and coders for a list and support. There's so much more than you thought was there, which is so true. We really don't focus on that as much in a military residency program as we probably should. And last year, staff is your family. They're your eyes and ears. Treat them like gold and they'll have your back. The end of residency does not mean the end of learning. A great and hard thing about EM is the breadth we do. You will continue to see and do things you've never seen or done before. What residency provides isn't just the exposure to specific disease processes or procedures, but the ability to work through and adapt to challenging situations. You're ready. Also, find supportive colleagues, ask for help, get feedback, be curious, and never stop learning and growing. It's easy to get busy, especially with multiple hats, such as EMS, med director, etc. Stay on top of board studying, prioritize education and training to stay current with evidence-based medicine, advocate for yourself and your colleagues, and don't let ultrasound skills go. And last one, which is actually 5. So reading x-rays without timely overreads made me wish I had spent more time looking at my own films in residency. POCUS is a valuable tool. Learning to integrate it into your workflow as a resident is far superior to coming back after a decade to learn it. And if you do it with ODE, you can bill for it. 3, always read the EMS report and talk to family when caring for confused elderly. Very, very true. 4, it's okay to say no, thank you. A lot of people will ask the new person to do a lot of things, and it's okay to say no. It's okay to enjoy your free time. And last, build a team of moms and dads if you're able to, so you can support one another and not miss important family life events. Well, that's all that I have here for lessons learned. Actually, my last slide. I'm going to close this out. Does anyone have any questions or comments? All right, so Dr. Stewart, aside from the basics, what's one opportunity or thing you recommend new grads look into or doing? I think the big thing is to just come up with some sort of routine. You will have so much free time that you will find yourself a little bit overwhelmed with how much free time you have. So if you have a weekly routine, like I'm going to always listen to the ECG weeklies on Mondays, or Tuesdays on my way to work, I'm going to listen to MRAP. Anything like that can really be helpful to give your life a little bit more balance because we have crazy shift schedules. So I wish I did that more. I think it would have made my life a little bit more organized, but I think that's something I can recommend to everyone. Anyone else have questions or comments? All right. Yeah, thanks, Matt. Glad that you can attend. All right, Dr. Stewart.
Hey, Katie, thanks for this. Your list is fantastic. Guys, I'd really encourage you to look at it. If you don't know, Sean Stewart, I've been in attending a little bit longer than Katie, and her list of what to do looks like all the things I didn't do. So it's very easy when you run out in attending life to forget simple stuff. So definitely look at her list. And the only three things I just want to echo, because she did such a great job of it, was for the license, also remember if you're going to moonlight, you need a DEA number. So again, I didn't think about that. I got my license, I got ready, and then realized I didn't apply for a separate DA number. Secondly, the I Love Me binder, great idea, regardless of what we're going to do. Again, even if you're going to get out, very quick, like I'll put some stuff in a folder, I'll keep track on Notepad. And next thing I know, like I had lost track of everything from, my different certs to when it's time to update my CV, what I had done. So I cannot encourage you enough at the very get-go, come up with a system that keeps stuff. And then finally, she said, don't feel bad. I mean, I still talk to colleagues to this day, what I guess 10 years plus out. Don't feel like you have to know everything and find those contacts. So again, this is Navy, but technically, regardless, you could cheat. We're not going to throw you away. Um, Portsmouth 1365, everyone in the fleet knows, calls the ED, and we're here and we know we answer phone calls 24 hours a day. Same thing for Portsmouth. We have the Bone phone. It's 953 Bone. Same thing. And I've used that deployed when I had a humeral fracture dislocation with nerve entrapment. I couldn't reduce it. And I called an ortho. I was like, hey, look, I cannot get this thing back in. And he said, hey, do you have a big hemorrhagosis with it? Yes, tap it. So again, find those resources. And again, even as you get more senior, don't feel bad about reaching out. We all get stuck now and then. But Katie, great job of summarizing all the things I did wrong when I transitioned.
A lot of it's lessons learned from me too, things that I had no idea and I wish I had known. So hopefully you all can be more organized than I was as well. But if anyone's interested, we are going to have this recorded and we'll post it through the GSMRA page. And if anyone wants to reach out, you all have my email. I can send this to you. I have no qualms. I'll probably just remove my pictures. So that way you don't have to completely look at them. But thank you so much for attending our second uh, of our quarterly webinars that we have started so far. And I'm very glad that you all attended.